Hello and welcome to this presentation by Kidney Health Pelvic Pain and Endometriosis Clinic on pelvic pain and sex. My name is Alice Waddell and I am a pelvic health physiotherapist based here in Geelong. I would first like to acknowledge that I am recording this presentation on water on land. I'd like to acknowledge the traditional owners and pay my respect to elders past and present, and acknowledge any First Nations people who may be listening to this recording. I would also like to acknowledge that I am presenting this session from a privileged position as a cis, straight, white, able-bodied, tertiary educated person, and this is the lens in which I see the world and therefore the content I'll be delivering today. This presentation may contain gendered language and themes. We recognise that endo and pelvic pain can affect individuals of all gender identities and strive to be inclusive in our approach. We welcome any feedback you may have. This presentation is intended to be general information and you may wish to seek further assessment from a health practitioner. Intimacy and sexual function can be a difficult topic for some, particularly if there is a history of trauma. Please take care in listening and learning, and please feel free to take a break at any point. This presentation is focused on those of all genders who experience pelvic pain and have a vulva, vagina, and/or clitoris. Whilst people with other genitalia experience pelvic pain, this is not the focus of today's presentation. Please be aware that there is support available if you require it. To explore pelvic pain and sex, we first need to explore what is sex. For most people, sex is considered to be occurring any time the genitals or the anus are stimulated for the purpose of pleasure or arousal. This can include penetration of the vagina, penetration of the anus, outer touch or clitoral stimulation, and an orgasm may or may not occur. For the purpose of this presentation, we're going to discuss in the context of penetrative vaginal sex. Sex can mean different things to different people, and sometimes when we focus just on the penetration, we forget about the many other acts and components of sex. This can be really important when recovering from painful sex, as it can often be helpful to recognize the parts of sex which you like and which you don't like. And this can be helpful when we look at arousal and desire and trying to build back arousal in the body, especially when pain has been a component. Research has found that a restrictive definition of sex was associated with increased sexual distress, whereas sexual self-esteem, relationship satisfaction, communication of pain, and sexual agency were associated with reduced sexual distress. So what does sex mean to you in your life? Is it about pleasure for you, pleasure for your partner or partners, orgasm or ejaculation? Perhaps it's about conception or intimacy. Is it a chore and something that you're doing to maintain your relationship? Thinking about what have you enjoyed about it, or what would you like to enjoy about it? Also considering the many factors that can contribute to our understanding and our thoughts and beliefs about sex. So what have we been taught? How was sex spoken about as we grew up? And what were the messages from the people around us? It can be really important to recognize the many consequences that come from painful sex, more than just the difficulty in engaging in the physical act. The many flow-on effects can take a big toll on us and our relationships. It can be easy to feel alone and isolated in these feelings, as it's often not a topic we discuss or talk about openly. But this can lead to further distress and pressure around sex, which can further exacerbate the suffering that can be experienced in the presence of painful sex. We know that from research there is a very large proportion of people with a vagina will engage in penetrative sex despite having pain. This is seen in the highest proportion of people engaging in heterosexual relationships. Themes of why someone does not disclose their pain were reported as fear of disrupting the moment, concerns about partners' feelings, social pressure and embarrassment, initial pain that fades eventually, avoidance of awkward conversations, or shame. But it's really important to recognize that painful sex cannot heal painful sex. It can only reinforce it. Every single one of us will have individual influences on our experience of sex, our experience of pain, and our experience of painful sex. No two people are the same. And it's important that we consider for you what things might be at play, as this can help us to then best be able to address and treat. It often isn't just one or two, but often a multitude of factors that influence on a number of different levels. Sometimes we see that certain factors are acting as drivers and others are contributors or may have developed secondary over time if we continue to experience pain. But it's really important to recognize that anything and everything can have an impact on sexuality. This is a note that if you experience vulval pain, being pain at the inner or outer labia or lips, the clitoris, the urethra, or the vaginal opening, and you have not seen a doctor about this, that we really strongly encourage you to do so. Infections, STIs, and skin conditions can contribute or cause vulval pain, and we want to ensure we are treating these appropriately. Vulvodynia is the term given when there is persistent pain or discomfort in the vulval area, present for at least 3 months, and there is no sign of irritation, infection, inflammation, or skin conditions. It can be generalized, meaning it's all over the vulva, or it could be local, affecting specific areas of the vulva. It may be provoked, meaning that the pain only occurs with touch, such as inserting a tampon, attempting penetrative sex, or wiping with toilet paper, or it can be unprovoked, meaning the pain can be there all the time or occur without touch. People who have vulvodynia may describe their symptoms as stinging, burning, tearing, stabbing, and people who are sexually active will report that it's often extremely painful or impossible. But treatment is available, and it may involve pelvic health physio to help desensitize the tissue and aid in relaxing the pelvic floor muscles, possible medications to help calm down the nerves in the area, psychology or sexology to support relationships and intimacy, as well as distress around these symptoms. Our pelvic floor muscles sit at the base of our pelvis, and they provide support to the pelvic organs, being the bladder, the bowel, and the uterus. They also work as a postural muscle to help us move about our day, and they maintain our continence for the most part of the day, but then relax to allow us to empty our bladder and our bowel. They should also relax to allow for penetration of the vagina, being a tampon, a finger, penis. Our pelvic floor muscles are just like any other muscle in our body, and they can get tight, and this can be for a number of reasons. It might be that genetically you have tighter or stiffer connective tissue. It might be that someone has experienced pain, whether it be attempting to insert a tampon or a painful examination or penetrative intercourse, and because it hurt, the muscles have reacted by tightening to protect the area. And for some people, if there has been a history of trauma, such as a sexual assault, then the muscles are much less likely to react by going into a spasm, the main reason here being to try and keep you safe. If it hurts, then the muscles will tighten and tense further in response to the pain. And this is where pelvic health physiotherapists can be helpful members of your team to help you learn about your muscles and get the best and be able to allow them to relax when we want them to. In the context of penetrative intercourse, we must discuss arousal and desire. The vagina is not just ready for penetrative intercourse. There must be arousal. Arousal refers to the physiological changes that happen in the body in preparation for sex. And to get arousal, we need desire. Desire is the mental wanting for sex. When experiencing pain with sex, it is very likely that your desire will drop. Why would we want something that causes us pain? And in the same way, if you don't have desire, you may not become aroused or ready for sex. And therefore, this means that the body's not ready, and this can lead to pain. So often what we see is that this becomes a bit of a snowball effect and a vicious cycle that you can get stuck in. But we cannot skip desire and arousal and expect sex to be pain-free. So the physiological changes that happen in the body in response to arousal is that vaginal canal lengthens, meaning the cervix moves higher and creates more space. We get increased blood flow to the genitals, increased lubrication of the tissue, muscles relax, sensitivity levels to touch change. So what happens if we don't get these changes? When these things don't happen leading up to penetration, what follows may be an uncomfortable experience. The relaxation of muscles and lubrication is important to allow for penetration to occur without friction or significant resistance. It's also important to note here that a person's lubrication is not a direct correlation to how turned on they are, and therefore often using a lubrication to assist can be extremely beneficial, as it allows the experience to be more comfortable from the beginning, which can further enhance desire and arousal in the moment. A person with a vulva's readiness for penetration can take anywhere between 15 to 45 minutes. Chances are, when you learnt about sex, you only learnt about one type of desire, spontaneous desire. This is the form that is shown in movies and media, in pornography, and in sex education. It is desire that is easy to access. It doesn't take much to awaken this desire. Just thinking about sex or looking at your partner can awaken it. It thrives on new things like adventure, excitement, change, and discovery, and hence it's often quite prominent in the early stages of a relationship, or often when couples go on holidays. Responsive desire is another type of desire, and this is just as common, but often not as easily accessible. It only forms in response to something, so it needs more sexual stimulus to activate the accelerators. So longer and good quality foreplay is really beneficial. Many people with this form of desire don't have a want or a need for sex, even if they think about it. But often what it requires is a bit of a leaning into intimacy, but without the pressure of committing to sex, to see if it awakens a response. Many people report that once they start intimacy, then they start to enjoy it. It just takes time to kind of wake up this desire. Leaning in does not mean engaging in unwanted things or convincing yourself to engage in unwanted touch. If the body is shouting no, then listen to the body. It can be really frustrating when it's not easy or accessible to engage in spontaneous sex. But remember that the society that we live in frames spontaneous desire as the only type, and this is not the case. So if this is not you, that is okay, and you are not alone. The dual control model of sexual response discusses what we call the sexual excitation system and the sexual inhibitory system. Think of this as accelerators and brakes in a car. So the sexual excitation system, SES, is accelerators for your sexual response. It scans your environment, including everything you see, you hear, you feel, and it will send signals from your brain to your genitals to accelerate or turn on. So examples of this might be certain types of music, sexual or sensual massage from a partner, intimate time together, touch of body parts that feel safe, certain smelling candles. The sexual inhibitory system are the brakes, and they send messages from the brain to the genitals to turn off. So examples of an SIS might be your parents coming home when you're in the middle of having sex, or worrying about having an orgasm, thinking or stressed about other things in your life, a crying baby in the room, or pain. So considering for you What is the balance between your brakes and your accelerators? Are there more accelerators than there are brakes? Or perhaps it's the other way around. This is constantly going to change. It's never going to be the same because life is constantly different. And so sometimes recognizing perhaps why we can't feel like we can get in the mood for sex or our arousal's not happening might be because there's too many brakes happening. Tension can be within the whole body, but specifically within the pelvic floor muscles. If you have experienced pain, your body and your brain get pretty good at remembering this, which means that they will start to anticipate the pain. The response is to guard against and to go into protection mode. This means that at the time of penetration, your muscles might be tight and tense, so therefore it hurts, and the anticipated pain is reinforced as correct, and often the pattern gets stronger. The more times this happens, the more prepared your body is to protect against the pain, and this can become a vicious cycle that your body gets stuck in. This is a mind-body model which is being created by Dr. Anita Ellis, who is a general practitioner who's trained in individual, couple and family therapy and specializes in the work of sexual medicine and sexual and relationship therapy. She is the head of sexual medicine and therapy clinic at Monash Health, as well as working privately. So she talks about considering what we need in order to engage in enjoyable sex, that being that we feel free, that we feel safe, that we feel relaxed, that allows us to become aroused, which is what allows us to enjoy or have satisfying, pleasurable sex. So considering perhaps what is missing from this for you, or perhaps what is getting in the way. So is there the pressure of duty? I should be doing this. I need to do this. Is there worry about, but it's going to hurt and I hate the pain? Therefore, we get the tension, therefore we get the lack of arousal, and often what that ends up in is an inability to engage in sex. When there has been an experience of painful sex, the body may be recognizing that at the time of intimacy, things may be unsafe as it's anticipating pain or discomfort, and therefore the brakes will be activated. And this can be really challenging to navigate, and often a challenge in a relationship because sometimes there can be a bit of a misunderstanding. It is not the intimacy that you are avoiding, but the pain. If you're in a sexual relationship and stuck in this cycle, often what can be helpful is to have an open conversation with your partner or partners about the pain that's occurring at the time of vaginal penetration. A partner's support here is really essential. If you do not feel comfortable or safe to say no to something, then your body is going to stay in a fight or flight protective pattern. So some things that can be beneficial to begin with, and a lot of this stuff can usually be done in conjunction with a pelvic health physiotherapist or a sexologist or even your GP. So for a lot of people who are experiencing painful sex, taking sex or penetration off the table for 1 to 3 months can give your brain time to retrain that intimacy and touch is something that is pleasurable, welcomed and safe, and not something to be feared. Learning to understand your anatomy if you feel safe to do so. Touch of the vulva and the vagina, which may be not for arousal or self-pleasure, but just more for exploring. Mirror therapy, meaning having a look at the vulva and the vagina with a mirror so that you start to understand your own anatomy more. And perhaps understanding your muscles, which is where the physio can be really helpful. Learning what it is that you like, not just what you think you should like. And then a gradual reintroduction of touch away from the genitals. Then what we often look at doing is gradually reintroducing the genitals. And this might start with outer course, so all the stuff that doesn't involve penetration. It's really important that there is communication with your partner here, And it might be starting with self-touch or self-penetration to build up safety first. Consider seeking support from a sexologist who specializes in helping people and their partners explore all of these things. Can be a really safe and evidence-based way to support you and your relationships. Everyone's arousal toolbox will be different. It's about working out what is in yours and what can help to build back up arousal. And a lot of this stuff is around what feels safe, what makes you feel safe. So is considering the environment, considering the body area touch, and then considering outer course. Slowing down, pausing, and stopping and checking in is always essential. Trying to engage in things that bring intimate and pleasurable moments more than just penetration or orgasm. Thinking about sexual, intimate experiences that can be pleasurable for all parties involved. There is no right or wrong here. Considering you as a whole person. You are more than just a vulva or a vagina or a pelvis. You are a whole person who is having a whole body experience. And it's really important that we're addressing and treating all aspects. You are not alone. Painful sex can be really difficult to navigate, and sometimes you need professional support, and there is nothing wrong with this. Your GP, a pelvic health physiotherapist, psychologist, sexologists are all here to help. Thank you for listening, and I hope you have learned something.